Arjun, you can start.
Yes, ma'am. A very good evening, everyone. I am Arjun Ramanathan, and today I am joined by Abhirami Girikrishnan, ma'am. It's my pleasure to be present today and welcome you on behalf of Indian Medical Association, Medical Students Network, Tamil Nadu, and formally open this question and answer session on the topic clearing misconceptions about women's health. We are currently in the middle of a pandemic, and the whole world has turned its attention towards better healthcare and lifestyle changes. Healthy lifestyle is one of the most widely discussed topics today. We witness a growing consciousness and awareness regarding health guidelines and practices among the people. Sanitation and hygiene have become so essential that not even a day passes by without talking about them. In spite of all this, women's health is still one of the many areas that seems to have drawn less attention and importance despite its gravity, either because people feel hesitant to talk or discuss about it in public forums, or they haven't yet realized its importance. The organization of the feminine human body is extremely astounding and is considered one of the most evolved structures on earth. Thus, it requires special attention and detail in terms of medical practice as well as care, which is why we have dedicated an entire arena called obstetrics and gynecology as a crucial part of medical study and practice. Despite the vast reach of social media and awareness programs, the number of myths and taboos regarding women's health is still alarmingly high. But the fact is that relying on these misconceptions can cost a person her life because believing and following these myths is equivalent to neglecting professional medical health. Hence, the main aim of this session today is to spread awareness among women and guide them in the right path towards their better health and well-being. We sincerely hope that this session will provide answers to many of your queries regarding women's health, so kindly stay tuned with us. The link for the certificates will be posted in the comments section for a short while during the session. Kindly watch out for it and fill the form in the link to make sure you receive your certificate of participation. Now, I request Abhirami Girikrishnan ma'am, General Secretary of the Events Subcommittee, Indian Medical Association, Medical Students Network, Tamil Nadu, to introduce the speaker for today. Over to you, ma'am.
Thank you, Arjun. Good evening, everyone. Dr. Vaishnavi is a consultant gynecologist, obstetrician, and urogynecologist currently working at Kaveri Hospital, Chennai. She has specialized in obstetrics and gynecology in India and abroad. Dr. Vaishnavi is an alumni of the illustrious Madras Medical College. After completion of her MBBS, Dr. Vaishnavi was selected to the MD program in obstetrics and gynecology in the same premier institute. Following completion of her MD, she obtained a much coveted British Council sponsorship in the view of her academic achievements to train in United Kingdom. Dr. Vaishnavi went on to work in multiple centers in the United Kingdom and gather experience and expertise in various specialties that were hitherto not available in India for a period of more than 10 years. During this period, she was awarded the membership of Royal College of Obstetrics and Gynecology and Diploma of Faculty of Sexual and Reproductive Health. Dr. Vaishnavi was also selected to a substantive consultant post in Dundee through competitive interviews in 2012, immediately following a certificate of completion of training in the United Kingdom. However, she returned to India in 2016, having given up a consultant post in a large university teaching hospital in the United Kingdom, with the sole aim of making a difference to the care of women in India. Dr. Vaishnavi is a feminine protagonist for a voice of women, especially the less privileged and vulnerable. Dr. Vaishnavi has a keen interest in the community, gynecology, and preventive health. Dr. Vaishnavi is also the founder and director of PenCare, an organization and a web portal that works rigorously towards women's health. Thank you, ma'am, for joining us today amidst your busy schedule. We would like you to share a few words before we begin the session. Over to you, ma'am.
Hello, Abhirami. Good evening to everybody here, and thank you very much for inviting me to present at this session. Very happy to be here. It's always a pleasure to teach young medical students, especially those who are extremely motivated like yourself. Without much ado, I think we get started. And this is like such a good opportunity, not just for all of the students and all of the audience of this session, but for me too, because it is an uphill task. And with this very view, early this year, I started a web portal called PEN. And the main aim of PEN is to dislodge myths such as this. It's to promote awareness and knowledge amongst women, because unless women are aware, how are they supposed to bring themselves up to the doctor, to the healthcare system in a country like ours where there's no safety net? So with this particular view in mind, we work vigorously and rigorously at PenCare to bring about awareness among women folk of all ages. So it gives me great pleasure to present at this meeting, to talk at this meeting, to address these very same myths, the very same boulders to accessing healthcare. So I'm happy to address any questions, and I know Abhirami has a very interesting set of questions lined up for me already. So I'm happy to get started as well now, Abhirami, if that's what you have planned next.
Yes, ma'am. Before that, the state coordinator will have a few words.
Sure. Thank you.
Thank you, ma'am.
Thank you, ma'am. Thank you for a wonderful introduction of the session. So myself, Raghu, State Coordinator of IMA-MSN Tamil Nadu and Chairperson of Event Subcommittee. It's a great pleasure to have you here, ma'am, for this wonderful session initiated by Abhirami and the team from the Event Subcommittee. India is a country where we have more maternal mortality rate, as well as there's a great need to address the women's health issues. Particularly, that is what the government is also trying to do through various schemes and RMNCH2. So I guess the public must understand what is their need and what should be the understanding about their own health, so that they could get the health facilities to get more educated about the health condition, what are the common problems they face. And thus this session will help them a lot. Apart from a medical students, it is also going to help the public too. It's a great initiative. Thank you so much, ma'am, for joining with us today in spite of your schedules. Thank you, Abhirami, for this wonderful initiative. Best wishes to entire team. Thank you.
Thank you, sir. Ma'am, can we, with your permission, shall we begin the session?
Yes, please.
Okay. Is it necessary for a woman to visit a gynecologist even when she's not pregnant or does not have any problem? If yes, how often should she visit?
Very interesting first question. Like I said, I did, we had a little chat before this actual meeting about what myths we were looking at. And Abhirami already had a very interesting set of questions. So I suppose beginning with a very interesting question by itself. So in our country, up to the age of 12, women, young girls are very well taken care of because they see their pediatricians. Their parents take them to their pediatricians. After the age of 12 and until the time of, say, pregnancy, there is a huge hiatus in their healthcare. So to answer your question directly, yes, it is very important. And if you ask me if it is necessary to come every year or every 2 years, if one is aware of what is called the red flag symptoms, then it is enough to come or see a healthcare provider, such as a general physician or a pediatrician or a gynecologist, when they have a red flag symptom. But given that majority of our patients are lay people who have no prior medical knowledge, they do need to just attend at regular intervals. For instance, your dental care. You need to attend every 2 years or every year to make sure your teeth are checked out and you're all fine. Same with your eye care. Same with your gynecologist. After the age of 12, or at least at the time your puberty starts, I think it is very essential that you attend your gynecologist at least once in a year. And if that's too difficult, at least once in 2 years. Gynecologists are not difficult to find, even in small villages and towns. So it is important to have that regular review. And as medical students, you'll know that a lot of the gynae conditions aren't limited to older women as much as older women have their own set of gynae conditions. The younger women aren't necessarily free from gynecological problems. For instance, ovarian tumors, we see quite common in young girls, and these young girls come very late, in a very late stage of the ovarian tumors, or ovarian cancers, not unheard of either. Similarly, anemia is something that I see very, very commonly in young girls. Now, anemia by itself will cause a significant change in quality of life, a significant dip in quality of life in this very essential years that are very essential for you in that you're studying really hard. It lays the foundation to a future career. So it's very important that these years are fruitful and productive like it should be. And imagine if you're anemic and your hemoglobin is so low such that you're not able to attend school, for instance. You're not able to play your favorite game. You're not able to go out and spend time with your friends. That's really sad, and you never knew about it. So it is important that you see a doctor and have your hemoglobin checked, especially if your periods are heavy. Now, this is a real problem for young girls because if I can elaborate a little bit, you don't know what your periods should be like, right? When your periods start and they're heavy and you bleed and you flood and you have lots of clots, then you just reckon that this is the normality for you, and you don't know it other ways. So unless you see a doctor who's able to kind of decipher that this is not normal, it is very difficult for the young girl to pick up these symptoms and come and press into you. So that is why it is important that they have a review with us as often as maybe once a year. Now, again, a condition that I see very, very commonly in young girls, polycystic ovarian. And polycystic ovarian disease is a metabolic disorder, extremely common, and we're seeing such a huge surge. I see a couple of patients in my clinic every day, very young girls, and I think it's a lifestyle disease that is presenting in the young. Just like coronary artery disease, it's a lifestyle disease in the older people. Now, invariably, these are young girls who are overweight or obese, who have diminished physical activity. And it is unbelievable how a little encouragement in the right direction, a little bit of regular physical activity, maybe just even taking up a sport, cures them of this metabolic syndrome. And it is something that they know that they can be stuck with for the rest of their life. So again, who does this? Whose role is this? I mean, not all mothers know what polycystic ovarian syndrome is or what the symptoms are. So when they come to clinic and tell us, I've not had a period in 3 months, some of them are actually relieved that they've not had a period in 3 months. But it's not necessarily a good thing, because your periods are a little window to your health. And the fact that you don't have your periods every month or every even 35 days is a symptom that something's not right. So as the examples go to illustrate for themselves, it is very important that a young person before their pregnancy have regular gynecological checkup. And I reiterated this at plenty meetings, and I'm of this strong view. Thank you.
I'm sure that was helpful to all women out there, ma'am. Shall we go ahead with the next question?
Yes, please.
Yeah. Menarcheal age has declined over the last few decades. Since girls are at a very tender age, they often feel afraid and insecure to inform their parents. What are the adverse effects of early menarche? Also, what is the best way for a parent to prepare the child for the same?
Again, very good question that. I recently, and interesting that you asked that again. I recently wrote an article which got published in Kaveri's public health forum, as well as is available on our website on pen.care. And it beckons the question, why are our young girls having their periods so early? there is a thing called precocious puberty, and I can talk about it because there's doctors here mostly. And basically, it is precocious puberty refers to young girls who start their period before the age of 8. Now, that is not such a huge deal because somebody starts a period before the age of 8, they're promptly brought to the doctors and they're investigated and they get the necessary treatment. However, it is the girls who have their periods at the age of 9 or 10 or 11. They're still very young to start their periods and go through all of that. They're not mentally prepared or have the mental maturity to deal with it. So they have a whole set of problems. Now, your question was, why is this happening? And when we reviewed various articles on why this was a more prevalent problem just now. Now, the answers we got was obesity, childhood obesity, diminished physical activity, presence of pesticides in food, and one of the commonest agents that was present in food that was associated with early menarche was DDT, which is a pesticide that is commonly used. Phthalates or phthalates, as it's pronounced, that is found in plastic, again, is associated with early menarche. Now, mind there's no proper studies to give us real evidence, in which case we can actually act on it. So these are all studies which found a little associated evidence. So steroids in food, stressful upbringing, like for instance, if they were brought up in homes where both the parents weren't present, or they were in an abusive relationship, or they were brought up in an orphanage, a lot of stress in the family, basically, then these children were found to have early menarche. So plenty reasons, and they're constantly associated with early menarche. The early menarche by itself brings a whole lot of problems with it. So again, obesity and the other medical problems associated with obesity, such as coronary artery disease, hypertension, diabetes, becomes prevalent. Breast cancer, ovarian cancer is more prevalent in these young girls, and also kind of mental health issues, high-risk behavior. They're more prone to physical and sexual abuse. So these are high-risk individuals who need a little bit of special care, who need a little bit of counseling, a little bit of somebody, a little bit of time to actually speak to somebody about. So it is not an easy thing to deal with when somebody starts their periods, or young girl starts their periods at the age of 10. Medically, we're not too worried about it because we know there is a trend. We almost think it is how the world is evolving. We think that in the olden days, young girls weren't healthy enough, they didn't get enough food, so they only started their menarche at 13 or 14. So there are some researchers who think this is a sign of young girls getting more healthy and the world evolving. However, it is not easy for the young girls to deal with for the above mentioned reasons, and they need a lot of physical and mental support, both from the parents and doctors. And sometimes when these children come to our clinic with their parents, it's the parents that have all the questions and the parents that need all the support, as well as the young girls. Yeah. So I hope that answers your question. Did you want any more clarification in the aspects of that, Abhirami?
No, ma'am, this is good. Thank you. I'll move ahead with the next question. Moving on to the menstrual hygiene. There are many products available to maintain menstrual hygiene, like tampons, menstrual cups, sanitary pads, etc. Can you explain about each in brief? Is it advisable to combine a tampon along with a sanitary pad?
Again, it is quite gratifying that just the way the question's framed, because the last meeting that I was at was more a case of how do we promote sanitary pad use in young girls. And this is for an NGO, and they were using old cloth. They were using charcoal, left behind charcoal. They were using mud cakes to stop for menstrual hygiene during their periods. So there are aspects of this in our society too. So, and in India, it is, that is how it is. The society is it's just such a huge spectrum. On one end of the society, we have young girls who are quite happy using the menstrual cup and the tampons and want to do that for various reasons, to be active, to engage in sport. And at the other end, we have young girls who don't have access to any of this at all. And we're trying to get them access to clean cloth. And that's where we are. However, to answer your question, it's individual choice, and that's my opinion. So whether you're comfortable with a sanitary pad or the tampon, completely individual choice. Now, some young girls are not, or some even adults are not happy to insert a tampon, for instance. It's too much of touching themselves. It's too private for them. But some young girls feel, and typically younger people feel they're far more comfortable with a tampon because there's no soiling on the outside, and they don't have to worry about their pad overflowing, their clothes soiling. So I have quite a lot of patients who use a tampon and a sanitary napkin. Again, the menstrual cup is something which is very recent, and I have no worries about anybody using the menstrual cup. And I think it's very eco-friendly because apparently our landfills are filling up with the thrown out sanitary napkins, and our pipes are apparently getting clogged up with all the condoms that are not condoms necessarily, the tampons which are getting clogged up, as well as condoms apparently. But so it is very eco-friendly to use the menstrual cups, extremely eco-friendly to use a menstrual cups. But of course, high maintenance, meaning we need to make sure we wash it. We need to make sure we wash our hands. We need to make sure it's replaced regularly. Both, for instance, say if you use a menstrual cup, you need to be able to have the facility to go change the cup, wash it, reinsert it at least every 6 to 8 hours. Similarly, if the menstrual cup is damaged or if there's showing any signs of tearing or breakage, you need to be able to dump it and get a new one. So absolutely individual choice. But I know a lot of gynecologists who feel very strongly about moving towards the menstrual cup. Again, a lot of training involved, a lot of availability issues involved. And I think we have a few more years before we all move across to the menstrual cup. But in the meantime, the pad or the tampon is good enough. Again, tampon and menstrual cup have the same issues. Some women are just not, even when we give them vaginal creams for infection, they're not happy to insert the tampon into the vagina or insert the menstrual cup into the vagina. So if you're somebody like that, then it is just not for you. So it's about individual choice.
That is indeed very helpful because a lot of young girls seem to be confused about the usage of these products. So moving on to the next question, ma'am. Premenstrual syndrome is a common yet unnoticed disorder in India. We hear that it may progress to depression. What is premenstrual syndrome, and how should family members take care of someone suffering from it?
Premenstrual syndrome is just the changes that women go through prior to their periods. It is due to a rise in the progesterone hormone, and it is usually change in the mood, a little bit of irritability, a little bit of breast tenderness, a little bit of bloating, a little bit of everything actually. That makes the woman quite irritable, uncomfortable. But we know that premenstrual syndrome is not just that. And we have moved away from just calling it PMS and making a joke of it. We know we have societies now for what's called PMDD, which is premenstrual dysphoric disorder. And we know it's a huge spectrum. At one end, it's that little silly irritability. And at the other end, it's severe depression, to the extent that women can even be psychotic during these episodes. And it is not something that women are making up. It is just the way they are reacting to the hormones in their system. Treatment is available. We can manipulate the hormones. We can give the medication depending on what their symptoms are. And the treatment is mainly symptomatic. So if it is a case of bloating, for instance, then we give you treatment for the bloating alone. If it's mood swings, if it's really bad dip in the moods, then we give the patient antidepressants. If it is breast tenderness, then they get supplements. So it all depends on what symptoms they have. Some people have problems with libido as well during this time. So difficult time for most women, a time that the people around them need to be supportive. But the good thing is typical premenstrual disorder will disappear with the onset of periods, because it is due to the progesterone surge. And once that disappears with the periods starting, the patients will feel better. The women feel better.
Thank you, ma'am. We really hope everyone understands the seriousness of the issue and empathizes with women who are undergoing it. Shall we move on to the next question, ma'am?
Yes, please.
Does the usage of garments like breastweaves and other products like underarm antiperspirants increase the risk for breast cancer? Is it necessary for a woman to do a mammogram screening annually to rule out breast cancer?
Yeah, there's quite a lot. I get asked this question quite a lot. And in fact, I have most of my patients don't want to use deodorants because they're convinced. There's no question about it. They're just convinced that it causes breast cancer because they have friends who've had breast cancer and they've used the deodorant. Breast cancer, as we all know, is multifactorial. And the biggest causes for breast cancer is genetic predisposition and hormonal. So I don't know where the poor deodorant got involved. I have no idea. There are some studies that have looked at the link, and I know from these studies, I can't quote off the top of my head, but I know from these studies that they have not shown a proper link, a proper statistical, association between the deodorants and breast cancer, and the same applies to braziers. I have seen many women who stopped wearing the brazier because they think it causes breast cancer, and that is not on. I tell them all that they need to wear a bra or a brazier for breast support. And in fact, they get a lot of breast pain and a lot of breast tenderness, especially premenstrually, when they don't wear a brazier. What I do tell my patients is what brazier you wear needs to be well fitted and has to suit the climate of the place you live in. For instance, it's very fancy to wear nylon underwear, nylon braziers. But in a country like India, we need to wear cotton underclothes so that the skin's able to breathe, because it's just far too hot. It doesn't matter if it is underwired, if it's not underwired. Pregnancy and lactation is the only time we say to women not to wear the underwired brazier. Otherwise, there's no reason to have any restrictions about wearing a brazier. A well-fitted and a proper material brazier is a must for all women to give you proper support, to protect you from back pain, issues with breast tenderness, and the rest of it. Again, like I said, the deodorant, about the deodorant question, there's no real association. Same with antiperspirants as well. Mammograms, now the current guidelines is above the age of 40, all women should be screened for breast cancer. Just like how all women get screened for cervical cancer by having the pap smear from the time they're sexually active, from the time they start their reproductive years. But that, I think, is it's an ancient term. From the time they're sexually active is the right term, I think. So just like how the pap smear screens really well for cervical tumors, the mammogram screens for breast lumps and breast cancer. And above the age of 40, all women should be having mammograms. Now, there are different guidelines across the world, and I know we've adopted some guidelines from America, which is a lot insurance driven, and which says yearly mammograms. Mammograms aren't the most comfortable test to have. So I say to some of my patients, at least get them once in 2 years. You can get an ultrasound of the breast in between times. What about all the women less than the age of 40? Now, only if they are high risk, if there's family history of breast cancer, if they've had a lump which showed some changes that they're worried about, then they need to get screening and mammograms prior to the age of 40. If not, I do not screen my women before the age of 40. It is not necessary. And when breast tissue is replicating because of the hormonal changes, subjecting it to a lot of radiation from the X-ray, it is not necessary and might cause harm. But it is completely different scene for women over the age of 40, where it is recommended.
Your answers are extremely helpful in providing clarification to such doubts, ma'am. Moving on to the next question. All of us are aware that there are two forms of delivery methods, that is the normal vaginal and the cesarean or the C-section. We see an increase in number of C-sections nowadays. So what is the probable reason for it? And is it also possible for women to choose the mode of delivery?
So answering your question backwards, yes, it is possible for the women to choose the mode of delivery, but it should be an informed choice. And they should also be aware that there might be events in labor that will necessitate or require a cesarean section to be done immediately. For instance, if they have chosen a normal vaginal delivery and they have what's called fetal distress, meaning the baby's heart rate dips suddenly, then we need to resort to a cesarean section. So this counseling and this information should be made very clear to the mom and the partner and the husband. And together, of course, the woman has a choice about how she delivers. And that is about bringing back dignity into labor and delivery. So you as a patient and any of us should have a choice about how we choose to deliver. And that needs to be discussed beforehand, because delivery and labor is not necessarily a time to discuss these issues, unlike other medical conditions. So yes, choice is very important and is a must. And we are already giving our patients a choice of what they want to do. They get it's not a case of they get given the choice, but they get told what the options are and what might happen and what we aim to do for them. Is the rate of cesarean section going up? Most definitely. Especially in the private sector where I work, as well as the public sector, to be honest. But is that necessarily a bad thing? Probably not. In the public sector, I think the rise in cesarean section rate is reasonable. It's about 17%. The WHO says keep it around about 20 to 25%. But in the private sector, it's close to 40%, the cesarean section rates. I don't know where that's coming from. A lot of that is probably driven by patients and doctors. Managing expectations is the biggest hurdle we have in the private sector. What the patients expect and in the kind of time frame is all very difficult. And being averse to risk is the second factor that makes the rate of cesarean sections go up. For instance, if I say to a patient, there's a dip in your baby's heart rate, the CTG showing some changes, but you can still wait, give it some more time. Most patients don't want to wait. They just, and I can understand that. And it immediately causes a lot of anxiety. And patients want to resort to a cesarean section because they know it's an easy enough operation. X, Y, and Z have had it, and they've been really well after it. I'm not for resorting to cesarean section without reason, because any operation, any surgery done without reason, and you end up with a complication and you just can't justify it, both as a patient and as a doctor. So I'm not for resorting. Normal vaginal delivery is the most natural physiological way to have your baby. But if necessary, the rates of maternal mortality have come down because of resorting to cesarean section early. The rates of infant mortality has come down because of resorting to cesarean section early. So it has been a blessing in disguise, but I'm not sure the rates going up to 40% is necessarily a good thing.
Thank you, ma'am. This is one of the most frequently asked questions, and today we have obtained great clarity regarding the same. Can I move on to the next question, ma'am?
Yes, please.
Yes, thank you. Breastfeeding has been proved to be a beneficial for both the baby as well as for the mother. Yet there are many misconceptions associated with it. Does breastfeeding cause any change in the shape of the breast, like sagging? If yes, what advice would you give to the mothers who hesitate to breastfeed because of such reasons? Also, what changes in the mother's diet would you recommend during the lactation period? Over to you, ma'am.
That's a whole series of questions. That's a chapter I need to write, Abhirami, for you. Right. So breastfeeding is a boon to the human race, I think. Complete boon, complete blessing. And how it happens is magical. And anybody who's witnessed it or anybody who's seen it happen, the benefits, again, to the mother, baby are remarkable. And there's no reason to debate it at all. Breastfeeding should be universal. Breastfeeding should be the norm, at least up to the age of 6. I know a lot of our agencies suggest up to the age of 1. Exclusive breastfeeding, at least to the age of 6 months, is very important. Great mom and baby bonding, great immunity to the baby. And lots of goodness to the mom as well. It protects them from breast cancer too. Does it cause a little bit of sagging? And does it cause a shape in the change of the breast? Yes. And these are all changes that happen with age. Does that necessarily mean you have to stop breastfeeding? It's not necessarily an age thing. It is just a physiological thing, just like how your womb grows when you're pregnant. The same thing, your breast grows because they have to produce the milk. It's a gland and it needs to grow to produce the milk for your baby. And most times with return to normality in the postpartum phase, I won't even call it return to normality, return to the non-postpartum phase, if you like it, when they stop breastfeeding, most women's breasts possibly don't go back to the same as it was pre-pregnant, but to a normal, as close to a normal's shape and size. This begets the question, what is normal? Because things change, your body changes as you go through various phases in your life. For instance, I'm sure all of us know our body is not the same as it was at the time of menarche. It's not the same as what, at menopause, it's not the same as what it was when you had your baby. So your body changes with time and with life events. And this is one of the changes. It doesn't necessarily mean your breasts sag. As long as you're doing all the right exercises and you're not putting on too much weight, you should be able to maintain it in a good shape, really. So no contraindications whatsoever there for breastfeeding. Even moms who are very ill can breastfeed. Very young babies, we start them on breast milk. Very young preterm babies are on breast milk. And like I said, the benefits to both mom and the baby are huge. So definitely one that needs to be encouraged. So as medical students, and I suppose most of the audience today are medical students, and I know lots of people will ask you the question, should we do this? Should we do it? How long? And when you put out the right information, and when you put it out with no doubts at all, it makes a huge difference. Patients who probably would be at this stage, friends, relatives, neighbors, will take it on. And that's what we need. We need ambassadors of the true, the true facts. And that's what you all would be, ambassadors of the true facts and mythbusters, really. And especially with breastfeeding, I think a lot of people ask you guys for advice, and as long as they're given the right advice, it will be taken on. So I hope that was helpful.
Thank you, ma'am, for clarifying about breastfeeding. Moving on to the next question, is menopause menopause is a physiological milestone in a woman's health with a lot of changes in various aspects of health. Can you elaborate on these changes occurring during menopause? How does it affect with physical, mental, and sexual state of a woman? How can a woman prepare for it?
Again, transitioning into menopause. So a very interesting phase in a woman's life. So lack of hormones is the biggest problem in menopause. And there are huge challenges, physical, mental, psychological, during this phase. Again, I wouldn't call it a condition, but a phase that needs a lot of input from doctors, a lot of help. And most women don't necessarily get it. Women, I have colleagues, doctors themselves, who have terrible menopausal symptoms, but haven't realized it. Obviously, non-obstetric, non-gynecological doctors who haven't realized that those are menopausal symptoms. I have patients who have very poor bone mineral density, osteoporosis. At a very young age, they're only 47, 48. They have osteoporosis. They've broken a bone, but still haven't clocked in that they've stopped having their periods really early. They need to get the hormones in place so their bones are really healthy. I have people having young heart attacks, very young 40-year-olds, 45-year-olds, again, early menopause at the age of 40, and then they start having coronary artery disease because they don't have the protective effect of the estrogen and the progesterone hormone. So the estrogen gives you good protection for the bones and the heart. So as long as you have estrogen, as long as you have your periods, that is the benefit you have. Once you hit menopause, this protection is lost. And if you hit it too early, so the normal age of menopause is about 50, 52. And in our country, I would say around about 48. And that's the Asian average. If a patient attains menopause before the age of 40, that's called early menopause. And in that case, or it's called premature menopause. And in that case, they are recommended, or they are asked to take hormones so they can keep, they keep their systems healthy, basically their bones, their heart, the urogenital system. We see a lot of prolapses, urinary incontinence, vaginal burning, decrease in libido, sexual desire, all due to lack of hormones. And as much as we list them off as if they don't mean that much, they can cause quite a lot of upset. For instance, the sudden lack of libido and vaginal burning and things like that can cause a lot of difficulties in family between the partners, for instance, between the husband and wife, for instance, because when everything's been fine so far, there is a sudden lack of interest in a relationship, and the sexual relationship comes to a standstill. The same with the urinary incontinence. So this middle-aged woman who had a very active lifestyle, who was running, maybe doing a little bit of dancing, suddenly has to stop everything because she has urinary incontinence. And so it causes a significant change, like I said before, in a woman's quality of life. And when any condition does this, it is clear indication that intervention is necessary. But generally in our country, the ideas are that unless it's life-threatening, health care is not necessary. But these conditions that affect your quality of life are something that needs to be treated as well. So the treatment is usually quite simple. Sometimes it's hormone replacement. Sometimes it's other medication which are not hormones in women who can't take hormones. For instance, we do a drug called clonidine in women who have hot flushes. We talk about hot flushes and night sweats, which are pathognomonic of menopausal symptoms in the menopausal. So there's a thing called the menopausal syndrome. I'm sure a lot of you would have heard about it. So when patients have these symptoms, it can be quite debilitating. They don't know why they have this, and they usually go around in circles quite a lot. They've seen the physician, the endocrinologist, and a few other doctors before they come to the gynecologist. And all we need to do is put them on some hormones and they're absolutely fine. Again, people can have a decline in their cognitive function too, with early menopause and with menopause. They can suddenly feel like there's not that clarity. They feel that their cognition is declining. They don't feel as sharp. Again, plenty help available. And it's just something that needs to be brought up with your healthcare provider and with your gynecologist. So menopause as such is a transition in a woman's life that needs to be celebrated. Huge input required and quite a lot of roadblocks for most women to get that kind of help, because one, there's not that many specialists, and two, there's not that much awareness even among doctors about menopause and the physical and the psychological symptoms that it can cause.
Thank you, ma'am. I'm sure the question was helpful. Moving on to the last question for today's session. Let us now talk about a socially relevant issue. Women in India are mostly blamed for infertility issues and inability to provide an heir, with lots of name callings and insults. How can we as a society stand against such violence against women? And also, how far has India progressed in the field of fertility treatment, ma'am? Over to you, ma'am.
Infertility is a medical condition. There's lots of medical reasons for infertility, or I like to call it subfertility. And there's like plenty reasons, and the man and the woman are equally responsible, if you like. But there is no such thing as childlessness. And I say this to all my subfertile couple that come to the clinic. There's no such thing, because you can adopt a child. I mean, there are various ways, and we have very good systems in place. We have excellent doctors for treatment of subfertility. I'm not a specialist myself in subfertility, but I know we have the best of care in the world in our country. And so there's IVF available. There's various other egg donation, surrogacy. All of that is available in our country, and quite easily available and quite well in a well-organized way. So women can go to any extent to have a baby, but there are various reasons, male and female factors, that cause infertility. Now, there can be problems with the male in various ways. For instance, they can have a low semen quantity. They can have abnormal sperms. They can have problems with, actual sexual intercourse. Or in the same way with the woman, they can have problems with their ovary, their tubes, their uterus. So it's multifactorial. Why is a woman blamed for not having a baby? Just she has to take the brunt of it all? I have no idea. And it's almost like there are a whole bunch of people out there waiting to abuse this poor woman who's walked into a new home, away from her own home, is very vulnerable. And they just, it's just psychological abuse, really. And the stories that women tell you are just unbelievable. I think we should all stand against it, and in every possible way. Maybe you would see it with a friend, and maybe you would see it with your own family, and just standing up and saying, this is not on, I think is a start, because it's not necessarily the woman's fault. If she has a medical condition, and sometimes it's not even her fault at all, but that doesn't matter. If they don't have a child, is a couple's it's their problem. And why should the society call them names? Again, it's something that I just don't understand, but it happens quite a lot. And a lot of women are subjected to immense torture, both physical and psychologically, just for the simple reason that they don't have a baby. They resort to different means, including buying children that are not through the legal means. But adopting children is quite simple. There is an actual structure in our country, in our state. So adoption is not a bad idea at all. But then you have to go through the entire medical process. You have to have the assessment, you have to have the treatment. And if it comes to the stage where, in spite of all the treatment, you're not able to have a baby. Now, some people call it achieving a pregnancy. It's not a trophy to be won. If it's not meant for you, it's not meant for you. And we just have to look at other modalities. Now, I say to a lot of my patients, like, have a chat and see if it is really important to you. And you might find that, and at the end of this discussion between the husband and the wife, you might find that hey, and you might just say, hey, it's okay. It's okay if you don't have a baby and we have a life besides a baby. There's plenty of other things to do. So, and that's the couple's decision, and it's not for the society or anybody else to intervene. So I feel quite strongly about that. And we have to raise our voices, and we have to tell the family when they walk into your clinics, or when they'll walk into your clinics in future, that it's not on to blame anybody, and definitely not name call, not on at all.
Thank you, ma'am. With this, we have come to the end of today's session. It was extremely informative talk with Dr. Vaishnavi. It was extremely insightful and eye-opening. With this, I end with the vote of thanks. It was indeed an extremely enlightening session for all of us. I'm sure that the session proved to be an eye-opener for the audience. We thank you, ma'am, for taking your time off from your busy schedule for joining with us today. Thank you, ma'am, for patiently answering all our questions in a detailed yet simpler manner, which could be comprehended by all. I would like to thank the Indian Medical Association Medical Students Network, Tamil Nadu State Council, for supporting the event throughout. Special thanks to Santoshni ma'am, the General Secretary, Ravi Varman sir, State Conveyor, and Raghunandan Ramanathan sir, State Coordinator and Chairperson for Event Subcommittee, Indian Medical Association Medical Students Network, Tamil Nadu, for their continued support. I would like to thank Aravind from PenCare for his assistance. I would like to thank the technical team and the public relation team for helping us in streaming today's event and advertising the event. I extend my gratitude to all viewers who joined us this evening, without whom the session wouldn't have been possible. Lastly, I would like to thank the members of the Event Subcommittee, Indian Medical Association Medical Students Network, Tamil Nadu, for their efficient work in executing the event within a short span of time. It was a great pleasure to host the event today. This is Abhirami Girikrishnan, along with Arjun Ramanathan, signing for the night. Thank you. Thank you, ma'am, for joining the session.
You're most welcome. And kudos to you and the entire team for organizing this, and hats off to many more.
Thank you, ma'am.